Hello and good morning. My name is Kathleen, and I'll start by respectfully acknowledging my settler status on the unceded Coast Salish territories of the Wasanich, Lekwungen, and Esquimalt peoples, where I'm currently presenting from today. Today I'll start by discussing the context of my practicum, followed by some background information on the project and describe its purpose, discuss my role and selected results, and finally touch on the implications for public health. I completed my practicum with the Victoria Division of Family Practice, which is a not-for-profit organization that provides professional support to physicians and works to improve patient and provider experiences of care. I joined the Transitions and Care team as they embarked on a new coordinating complex care initiative to improve transitions and supports for older adults experiencing comorbid heart failure. In a nutshell, the project is focused on improving transitional care management for heart failure patients recently admitted to hospital through a combination of care coordination activities. So a little bit of background. Heart failure was chosen as the patient population in large part because of its complexity, disease prevalence, and high readmission rates. It's estimated that about 600,000 Canadians are currently living with heart failure. This number is on the rise with around 50,000 Canadians diagnosed each year. In addition, heart failure is among the top 5 leading causes of hospitalizations and has the highest readmission rates. Heart failure is a complex clinical condition. You can see the disease trajectory at the top right of the slide. It typically presents as a gradual functional decline in health with intermittent episodes of acute deterioration and small recoveries. It also presents with multiple comorbidities, adding to the complexity of care and the number of care providers sought for treatment. So, for example, in BC, between 2016 and 17, 19% of persons aged 65 and older received care from a family physician, plus 3 or more separate specialists, with cardiologists being the most frequent specialist seen. Receiving care from multiple providers can create a substantial burden for care coordination for patients and their families, as well as for the physicians trying to manage their care. In the local context here, a lack of coordination and communication has been documented between hospital and primary care physicians, where in many cases, family physicians may receive discharge summaries that lack appropriate medication optimization instructions, which is pretty important for managing heart failure, and advice to follow up, making it difficult to plan and manage care in the community after a hospital discharge. So the purpose of the project then is to develop quality improvements at each stage of a heart failure patient's journey, beginning with shared care planning between specialists, family physicians, and patients and their caregivers during the inpatient stay, enhance transition, discharge, and immediate follow-up supports, and to develop more coordinated care management in the community to avoid readmissions. Overall, it's expected the quality improvements will result in all people in the patient's circle of care being aware of the shared care plan and that the family physician is supported as the hub of a patient's circle of care. And I will go through the quality improvement interventions in more detail in a later slide. I will describe my role in the project. So the project is still ongoing. I joined during the last part of the stakeholder engagement phase. I contributed to the funding proposal by completing a jurisdictional scan of heart failure initiatives in BC and Canada, a rapid review of the clinical literature. I completed a qualitative data analysis of stakeholder engagements and a risk registry, and all of that was used to develop the funding proposal. I then developed a patient journey flowchart to map out the transition points of each intervention activity proposed. And my final contributions were to develop a preliminary project plan and help form the working group, and to determine key areas of focus and starting points for project implementation. So project implementation has recently begun and will continue through to 2022 in a 2-phase process. It'll focus on hospital side interventions and community side interventions using a plan, do, study, act cycle. And finally, a third party will conduct a final evaluation in around a year's time. So in addition, one of my main roles was to consult and develop relationships with different stakeholders. So I consulted with family physicians, specialists, Island Health Management. I worked with leads from other aligned heart failure project partners, Island Health's virtual care team, and representatives from the Heart and Stroke Foundation, and more. So what resulted from all this? In light of time, I will touch on the results of the literature review. I will show the patient journey flowchart, as well as the main aspects of the project plan. The literature review sought to answer two main questions: what transitional care interventions are used to enhance discharge for heart failure patients, and what are the impacts of transitional care interventions on clinical and patient-related health outcomes? So I used a combination of key search terms in PubMed and Google Scholar and targeted systematic reviews and meta-analyses and tried to focus on a Canadian healthcare context. The results show strong evidence that transitional care interventions are successful for heart failure patients. These interventions include self-care education, shared discharge planning, structured follow-up support, caregiver involvement, and coordination with different providers. However, it is the high-intensity interventions that include multiple intervention components at both pre- and post-discharge stages that are most likely to be effective than low-intensity interventions, such as, say, for example, just focusing on one component, like self-care education. The clinical outcomes include a reduction in unplanned readmission and emergency department visits, and patient-related outcomes include improved quality of life, survival, and satisfaction with care. Here is the patient journey flow chart I created for the project. I realize there are a lot of layers in this graphic, so I'll quickly go through it. The top row shows the transition points for a heart failure patient's journey from admission to hospital, inpatient care, pre-discharge activities, and finally transition back into the community. And that's broken up into hospital activities, patient caregiver activities, and family physician activities. The indicated in pink are the proposed community side interventions, which target quality improvement activities through messaging and support to family physician. And hospital side interventions are indicated in dark blue and indicate practice changes in hospital processes. And finally, indicated in light blue with a diamond, those are hospital practices by other projects that will be supported or leveraged as part of this project. So this was the main graphic that was distributed to our project partners and working group members to communicate the main intervention strategies for the project. Here's a table that was developed as part of the project plan and shows the same information as the patient journey flowchart, but it more clearly outlines the intervention strategies based on each goal. So the main goals, so the first is to facilitate clinician to clinician early on during an inpatient stay, enhance discharge and immediate follow-up supports, and to develop coordinated care management in the community. I will direct your attention just to that first column of the proposed intervention activities, as these will be pursued as part of the initial stages of implementation. So first, the project team will assess the feasibility of connecting the family physician to participate in the hospital team care rounds specific to their patient. And below that, the team is working on developing a transition document that expands the discharge material to include a medication optimization plan and a caregiver patient and caregiver focused follow-up schedule. And finally, the team is partnering with home health monitoring to promote this service for providers and their heart failure patients. So there are significant implications for public health. Heart failure is a major public health concern in Canada and globally. The number of people living with heart failure is expected to rise as the population ages and life expectancy increases. Given the evidence for enhanced transition and discharge interventions, coordinating care between providers is expected to have a large impact on supporting patients and improving community care management here in Victoria. The project goals are designed to be in line with the Institute for Health Information's modified triple aim framework, which is the pyramid displayed there. This framework is to improve patient and provider experience, improve population health status, and improve system efficiency. For patient experience, anticipated improvements include increased involvement in care planning, increased satisfaction and confidence in their care from assistants navigating multiple providers, and reduced risks of adverse events and readmission. For providers, anticipated outcomes include increased confidence and satisfaction with care coordination. And system outcomes include generalizable system, tools, and workflows for shared care planning, and reduce burden on the system by reducing readmission and emergency department visits. So thank you very much. I'd like to give a special thank you to my practicum supervisor, Kristen Atwood, who is the absolute best supervisor I could have ever asked for. I will be eternally grateful to her. Thank you to Nigel for all your help and support throughout the practicum process. And thank you to the PHSB staff, and a special thanks to Dr. Robert Behringer, my second reader, for all of his help with my culminating report now and into the future. Thank you very much.